Okay, welcome to Spine Conference. Today's discussion is going to be on cervical stenosis. Um, so I like case-based learning. So today's case, and just please interrupt me if you have any questions or comments. Today's case is a 70-year-old man with right shoulder pain. And he says anytime he bends his neck backwards, he gets a pain that shoots into his right shoulder. He's had it for years. It once it looked into, and basically on exam, he had a normal shoulder exam. When I do a quick and dirty shoulder exam, I do the full shoulder exam, but I usually just notate he can forward elevate both shoulders with no significant pain. And I ask people just a basic shoulder exam is if they can do a dive position like the children. You know, when children learn how to dive in swim school, they put their hands over their heads straight out. If someone can do that, their shoulder is fine. That's kind of like my quick and dirty. If you can dive like that, but the other things to do for the neck is a near exam for the shoulder is forward elevation. So behind the patient, you lift their shoulder upwards, and that's to check impingement. That's to check if the greater tuberosity hits the acromion. A Hawkins exam is forward elevation and external rotation. If you do that, that also causes impingement. The greater tuberosity hits up against the acromion. A Job relocation exam, that I rarely do. That's more for kids that are, that's mostly for kids that are athletes, that they subluxate. Basically, you try to dislocate their shoulder, and if you push down, you relocate their shoulder, they feel better. That's mostly for like pitchers and athletes, not the clientele that I see. And cross adduction exam is when you bring the shoulder, the elbow to the other side, to the other shoulder, and that stresses the AC joint. So that's you can do that examination in like 2 minutes. Does anybody want to add anything else to the shoulder exam that you consider significant? You can also test rotator cuff strength by. How about 10? This. Yep. So put right there. That's my next one. Put the back, so if you can put the hand on your back, that means you can fully internally rotate. That rules out frozen shoulder. If you can do that, you do not have a frozen shoulder. Frozen shoulder people cannot do that at all. And also, if you can lift the hand off your back in that position, which I can just barely do because I'm stiff and old, that tests the subscapularis. And then forward elevation, the top one, forward elevation of the shoulder with the thumb down. Isolates the supraspinatus tendon. And then the bottom one, external rotation of your shoulder, elbow at the side, tests infraspinatus strength. So these are all tests of the shoulder that you can do very quickly. But basically, if my quick and dirty is if people can do a swimmer's dive position and they don't grimace at all, or they do it quickly and easily, yeah, just like that. If you can dive like that, your shoulder's pretty good. You've got yours stiff. David, I'm going to give you my card at the end of the conference.
Yeah, I need it.
So this I've got a problem too. It's common. So this is so same man, his shoulder problem. Now he's a previous patient of mine. Last year he had severe right buttock pain, and he had a surgery. Basically, I decompressed his entire spine, because every single level was stenotic, and I wasn't sure where the pain was coming from. But this is his X-ray, and you show specifically, Aaron, what do you see? Tell everyone what's present on the lateral view, side view. Yeah, so you see all the discs are well maintained. The height of the discs are all well maintained, but just in front of the discs, anteriorly, there's every single level has these osteophytes or syndesmophytes that connect body to body. And this is not a degenerative disc disease pattern, because a degenerative disc disease pattern has a flattened disc, sclerosis of the end plates. The disc looks sick or arthritic. The disc looks normal here. So this is a different disease process. This is DISH. This is diffuse idiopathic skeletal hyperostosis. It's a totally different disease process. And probably in this room, there's probably 2 people that have it. I think I'm going to get it because both my parents have it. and I'm in the early stages. And I think a third of people have DISH after the age of 65.
What is that again?
DISH, diffuse idiopathic skeletal hyperostosis, is very common. I'll give you some more statistics in a second. But this is his MRI, which just shows multiple bulging areas. This is his MRI axial cut, which showed he had a large right L1, L2 disc herniation, and he had multiple segments of stenosis. So he had that surgery, and he did great from it. But he comes back because his neck is worse. So now this is his X-ray, and it's not a good X-ray. Sorry about that. But you can see what's interesting. He has this massive amount of bone formation in the front of his neck. You see that? A massive amount of bone formation, and the disc is normal. Kind of interesting, very unusual. I mean, that bone spur is almost as deep as the vertebral body itself. Did you find that? I think that's incredible. And this is the left one is a regular lateral, and then the X-ray on your right is a swimmer's view that allows you to see deeper into the spine. Basically the cervical thoracic junction. And the way you do a swimmer's view is you just elevate one shoulder higher and depress the other shoulder so the shoulders are taken out of the plane of the view. And then you can see the cervical thoracic junction. Otherwise, the shoulders are right at the same level, and the X-ray beam cannot penetrate it. It's just too much stuff there, too much meat, soft tissue, muscle, etc. But if you can make the shoulders at different levels, then you can see the cervical thoracic junction better. You can see it here. You can see down to C6, C7. You can see C7 on the side view. You can't see that. So basically, this point here correlates with that point there. So you can see a lot lower. But even this guy's a very big guy. It's hard to image him. You basically need a CAT scan to image him. Here's a front view and an oblique view. And these are some CAT scans, which is the only way really you can see the cervical thoracic junction in a person like this. And that's the other thing is the only way you can see the cervical thoracic junction in a big person with big shoulders is a CAT scan. You just can't do it on X-ray. And you can see, yeah, massive osteophytes. And what's interesting is this thing. Look how big this thing is. That's a very big osteophyte. And you see the vacuum sign phenomena in that big osteophyte where it's up against the vertebral body. So this disease process, diffuse idiopathic skeletal hyperostosis, it lays down this huge amount of bone. And usually the discs are normal and they don't get diffused, but in this case, you can see that the C3, C4 disc space is fused. See that? That's all welded together. He never had surgery. And what's interesting in this patient is that at C3, C4, where you see, C4, C5, where you see this this vacuum sign, that looks more like a hypertrophic non-union. Like, I'll show you some images, but so that area, C4, C5, looks like a hypertrophic non-union, like it's trying to fuse itself. Look at this body. The osteophyte is almost as big as the vertebral body. It's huge. And it looks like the spine is trying to fuse itself. Like, I'll show you what this is a hypertrophic non-union. So bones do not heal sometimes. And sometimes when they don't heal, it's hypertrophic. Sometimes it's hypotrophic, where there's no bone at all. But the other type of non-union is when it tries to lay down bone, but it just can't unite for whatever reason. And it's usually because it's unstable. There's too much motion at that segment. And then the bone overgrows like this. And you can see this is a case of a hypertrophic non-union. It's quite incredible. It's a massive amount of bone, and yet it doesn't heal. And it actually looks like an ankle, doesn't it? It's like kind of incredible because it just keeps trying to lay down bone, keeps trying to fuse. So these type of non-unions, they fuse if you just make it stable. So if you just put a plate on this, it would fuse. So any questions so far? Okay, and so this is a coronal section to the same patient. And again, you can see here that C3, C4, and C6, C7 are totally healed. He's totally fused, and he has two discs that are open, and he's trying to fuse them. So the MRI scan shows severe spinal cord compression at C4, C5, C5, C6. So you can see the discs are gone at C3, C4, and C6, C7 because that area has been fused. But at the two levels that are open, he has, which you can see, discs herniating, going backwards, compressing the spinal cord. And at C4, C5, he has posterior hypertrophy of the ligamentum flavum, which is compressing his spinal cord. So this is like, it's very, when he comes to the office, he doesn't complain of much, just some shoulder pain, but he's got a serious problem in his neck. Let me just, this is just another view, another study. So these are the axial cuts. C2, C3 is not too bad. You can see the circle, which is the spinal cord, and he's got just a central disc right up against the spinal cord, not really compressing it. At C3, C4, he's got left-sided stenosis. Here's the spinal cord's compressed on the left, but he has no left-sided symptoms, so that thing is asymptomatic. So C4 looks okay. C5, C6, you see the area for the spinal cord is nearly completely obliterated. See that? This is the area for the spinal cord. The spinal cord should look like this. It should be wide open with CSF about it, but see how the spinal cord is severely compressed at C4, C5, and I think it's like 5 millimeters. The spinal cord itself usually is 10 millimeters, so there's a lot of pressure on it. And then C6, C7 has a very small area for the spinal cord, and C6 is normal. C6, C7 is pretty normal, small area. C7 is totally normal. So this man is DISH, and diffuse idiopathic skeletal hyperostosis. And previous descriptions are Forestier's disease, senile ankylosing hyperostosis. And it, not only does it have spine problems, but it also has ossification around joints. It's also called spondylosis hyperostotica. But DISH comes from the guy in the corner there, Resnick. I think he's from UCLA. He described it first in radiology literature, and so you know how as doctors, how we do things is we don't know what something is, and then we group a bunch of people together. Oh, I've seen this 10 times, and they all look the same. They all look like brothers, and you group them together, and you make a diagnosis, and that's how you start to study disease. That's how we've always done it, like just clinically. So this is basically a radiographic diagnosis that Resnick pulled together. So it's his definition, but that's how we learn. And maybe in 100 years we know exactly what DISH comes from, and then it's not really DISH. But for now, that's a disease process.
Can you flash back to the reference for a moment?
Yeah. Mm-hmm. So that's a person who first diagnosed DISH. And DISH is not a serious problem. It's not like, I was thinking, DISH is not studied that much. And the reason why, it's not like Zika virus that's killing babies. DISH is just out there like smoldering in our society, making people stiff and maybe compressing spinal cords, but it's not a serious health problem. So we're not really studying it. We never will.
It's vague. Diffuse idiopathic skeletal hyperostosis. Could be anything.
It could be anything, yeah. So his definition was a diagnostic criteria was flowing ossification along the anterior lateral aspect of at least 4 contiguous vertebrae. So it has to be 4 in a row. The disc heights have to be preserved, and you cannot have ankylosis of the facets or the SI joints, because if you have that, it's a different disease process. It's ankylosing spondylitis. So this is a classic DISH, where along 4 areas of the spine, usually thoracic spine from T7 to T11, there's extra bone formation, and the discs are pretty much normal. And the bone formation is horizontal. You see how the bone spur is horizontal? So this is in comparison to the other most common spondyloarthropathy, which is ankylosing spondylitis. This is a different disease process. This one, the disc is maintained as well, but the osteophytes are in a vertical position. They go up and down, and they fuse the spine in that manner. So it's a very different appearing X-ray. And you can see the sacroiliac joints fused. So that's ankylosing spondylitis. That's a different disease process. You can see they're very different. And yet they both are bone-forming osteophytes and make the spine extremely stiff. So they're different disease patterns. But interestingly, you can find characteristics of some people that have both. They look like they're both ankylosing spondylitis and DISH. For example, our guy, um, on some levels, he's got this massive osteophytes, but in other levels in the cervical spine, they're just fused like ankylosing spondylitis, right? So he's not really, in the cervical spine anyway, he's not really fitting the exact pattern.
What is his thoracic spine? Did you X-ray?
I didn't X-ray his thoracic spine. I should. Actually, I will. I'll ask him to get an X-ray just for the educational
I'm
purpose.
just wondering why I haven't done the neck and everywhere else.
Oh, I'm sure his thoracic spine has it.
Sorry?
I'm sure his thoracic spine is disease. It's just not symptomatic. But I'll X-ray just to be complete. I'll X-ray and I'll send it to you. So just some
Oh, okay.
demographics, yeah. So you can see what it's all about when you look at the anatomy. Usually, the people are over the age of 30. It's more men than women, and it's most prevalent over the age of 50. And it's 28% autopsy specimens over the age of 65. So a third of all people get this. But then the other interesting thing that I think, this is my own personal theory, is that people like me, I think I'm destined to get DISH. I know we're not here to talk about me, but both my parents have it. But my X-ray doesn't look bad at all. It does have just a couple areas of osteophytes. So, but I'm extremely stiff. So what is it? A lot of people like me are stiff, have pain, and yet there's a normal X-ray. So you tell these patients say, there's nothing wrong with you, you're just faking it. But no, what it is that the patient is in his 40s, maybe 30s, maybe his 40s. He's got the disease process, but it's early. It hasn't manifested on X-ray yet. So we see these patients in the office all the time. We don't know what to do with them. So I think what they all are is just this early spondyloarthropathy, which has not been proven by X-ray yet. So you can imagine like this disease process after 30 or 40 years of it, it's obvious on the X-ray what he's got, what they have. But in their younger years, you don't know what they have because the X-ray.
But if it's not showing up on the X-ray, why did that happen?
It's starting. So it's probably getting calcified. It's probably laying down extra soft tissue. It's on its way to forming bone, because this bone formation doesn't happen overnight. It takes a very long time. And then when we do surgeries, Aaron, when we cut open the cervical spine, remember, it's like some of the patients have this really thick periosteum. It's like, boy, this is weird. This looks like it's trying to fuse itself. And the periosteum's under the microscope is sometimes like 6-7 millimeters thick, right? And we say, what is this? Why is this like that? I think those patients are early DISH, and they're on their way to having this bone forming process. Again, it's subclinical. We see them in the office and the X-ray is normal. They're having symptoms, which is, some people say, oh, you're just crazy, or you hurt yourself playing tennis. Well, I think a lot of these people are early DISH because it's a third of all people, which is a massive number of people. 30% of all people over the age of 65. So probably 30% of all people at the age of 50 have this in the early process. So anyway, that's my theory. So who are the risk factors? Patients who are at risk for metabolic syndrome, diabetes, age, metabolic syndrome has fat along your waist, and what's important is direction of the syndesmophyte. So if it's vertical, like the woman on the right, that's more like ankylosing spondylitis. But if it's horizontal, it's more like DISH. This is just a classic. You can see the horizontal osteophytes of DISH.
Now, if one looks up syndesmophytes in the dictionary, it says bone deposition of ligaments.
Yeah. Mm-hmm.
So is that's basically what?
Yeah. So what you're looking at, there's a ligament there. It's the anterior longitudinal ligament. So that connects all the bones in the spine. There's a ligament. So it deposits. Yeah, it deposits all along that ligament. So these things, the ligaments, usually like in a 15-year-old girl, when she's in gymnastics, all the girls in the 7th grade can do a back bend. Pretty much all of them can do that. You can imagine how much flexibility the spine has at the age of 15. But if you ask us to do back bend, I mean, all of us would fracture our spines. So all of our ligaments have gotten very, very stiff, and some of us are fused. But in childhood, nobody's like that. So the ligaments have a lot of flexibility in childhood, but as we get older, we develop these syndesmophytes, and that's how we get stiff. I think it's kind of interesting. So enthesopathies are just diseases where the ligament meets the bone. It can happen in the iliac crest, the ischial tuberosities, greater trochs, olecranon. So here's a patient with DISH, and you can see these massive osteophytes emanating off the attachments of ligaments. That's the anterior iliac spine. That's where the rectus comes from. Anterior superior iliac spine. Sartorius, I think sartorius comes from there. On the ilium, you've got the osteophytes. On the ilium, we have the attachments of the external obliques. And you can see in the anatomical specimen, they have these knobs of extra bone from where the tendons attach. And you can see this patient had DISH. You can look up at the spine. You can see the anterior lateral fusion all across where the anterior longitudinal ligament was. And in the foot, you can get the same spurs where the attachments on the heel. You can see on the back of the calcaneus, the tendo-Achilles attaches right here, and you get this calcification, and then they also get calcification of the plantar ligament here at the heel, which some people call heel spurs. As you can see here, this is a DISH where there's large osteophytes, more horizontal than vertical, and the disc heights are well maintained. The difference between DISH and ankylosing spondylitis is that the rib articulation with the spine does not fuse. So these are open in DISH. In ankylosing spondylitis, they're always fused. The ribs are fused. That's why a DISH person, when he or she takes a deep breath, their ribs move. Ankylosing spondylitis patients, the rib cage does not move at all because it's fused. So that's one test you can do. And this is just an anatomical specimen which was found from the Hungarian Plains cemetery remains. So they dug up I don't know why they did this, but they dug up the skeletal remains of ancient people in the Hungarian Plains, and they looked at the skeletons. They studied the skeletons. And we have the same thing in Cleveland. You guys heard about the
Cleveland?
Yeah, in Cleveland there's a skeletal depository of I think it's like 1,500 skeletons that they have in the Cleveland Clinic, and it's kept in a building. It's a great resource for us for orthopedics, and that's how we've studied all of our bones. So this is from in Europe. They have the same thing in Hungary, and this shows the bridging syndesmophytes all across the spine. And this is an interesting case where you can see the supraspinous ligament is ossified on the left, and when it connects the spine, this ligament is ossified, and here the ligament flavum is ossified. So I was going to go over normal, but I'm sort of running out of time. But normally there's no ligaments in the front. Normally, plenty area for the spinal cord and nerves. You have a normal spinal canal. There's just regular osteophytes. These just dermatomal distributions. I was just going to go over this, like dermatoma distribution. So what do we do with this guy who's got these two areas of severe stenosis? So the options are, there's three options. I haven't done the surgery yet, but I thought I'd show this case anyway because I thought it was very interesting. Option one is the top left, posterior laminectomy and fusion. So laminectomy to decompress the spinal cord and nerves, but then fusion because you want to stop this disease process. If you don't fuse it, he'll keep deteriorating, the discs will keep herniating, he may still have problems. Option two on the back is just laminoplasty. So you don't fuse it, you just open the area for the spinal cord and you let him move. The downside is that if he keeps moving, these two discs that are symptomatic may just keep getting bigger and cause more problems if you don't fuse it. And option three is an anterior approach where you go through the front, take the pressure off your spinal cord and weld it together. Well, the anterior approach for him would be difficult because it's so deep. I mean, his neck is very deep. Also, the anterior approach is a little bit more dangerous when it comes to spinal cord injury because you're going towards the spinal cord instead of the posterior approach where you move it, you take it away from the spinal cord. So you can see how the anterior approach is a little bit more dangerous.
Could you just shave off the edge of the disc that's ramming into the spine?
From a front approach, from an anterior approach, this anterior approach, you can take you can't shave it because the spinal cord's in the way. From the posterior approach, you can't.
Okay.
You can't get to the disc because the spinal cord's in the way.
Or
So the only way to take the disc out is from a front approach. Then you can see if, on the front anterior approach, the front approach, you're going towards the spinal cord, so you could compress it while you're removing it. The posterior approach, you just cut, and just remove it. So you're not really going towards the spinal cord with the posterior approach. So neurologically speaking, the posterior approach is safer.
What are
So
you accomplishing with the anterior approach?
you take the whole disc out. You take the offending disc out from directly, and you take it out, and then the spinal cord is decompressed. So if the disc is the offending mechanism, it's best to go through the anterior approach.
Oh.
So that's it. Any questions or comments or thoughts? Or I'm sorry this was a quick conference, but I have an emergency to attend to.
do you have any idea why some people get it and others don't?
No. I mean, all we know is risk factors of metabolic syndrome.
And this guy was morbidly obese, is that it?
He has a BMI 40, yeah. So he has metabolic syndrome, so he's at risk for that. But the no one knows the risks. Those are the only risks, other than age and metabolic syndrome, diabetes, age, high BMI, elevated uric acid, and metabolic syndrome. But I think age, just because people have it when they're younger, it just manifests when people are older. So it's probably over the course of many years. So DISH. So any questions at all about DISH?
No.
It's interesting. Yeah, it's interesting. Only spine surgeons really see it. And nobody else. Yeah, nobody thinks about it but us, because we have to deal with it. NSAIDs is just like an mild immune suppressant, anti-inflammatory. Yeah. Oh yeah. It blocks the inflammatory process. And probably immunotherapy, but there's negatives to that too.
This patient presented with shoulder pain.
Yeah, anything that compresses the neurological. This was shoulder pain. He says when I bend my neck backwards, I get shoulder pain. It was very clear. Maybe, yeah, maybe. Yeah, maybe. It's always good to have range of motion. Can't hurt. I don't think so. I don't think trauma is a predisposing factor. I think this is some kind of a disease process. It's not an injury process.
But sometimes you're just going after specific osteophytes, right?
Yeah. Yeah. Yeah, as a surgeon, that's what we're doing. We don't care about the disease process. We're just going after what's the disease process is causing a problem. So we're trying to fix that problem. I don't know of any. I don't know of any other than high BMI. Me personally, both my parents have it, so I'm sure there's I'm sure there's a genetic predisposition. I'm sure of it. But maybe if you're genetically predisposed and you keep a very thin body habitus, maybe you won't get it. I don't know. I think it cannot hurt.
What about the initial, now they're taking calcium supplements?
May make it worse.
For women, for men.
May make it worse. Yeah. Yeah, that's the new thing now. It's like there's like now a push backwards against calcium because it causes those things.
They're saying that a man over 60 or 70 was taking 1,200 milligrams of calcium per day.
Yeah.
That's a lot of calcium.
Yeah, and they have problems from the calcium.
It's fine conferences on imaging. I still